In this video, I will discuss about the importance of history and physical examination in neurological localization of lower motor neuron weakness. Whenever a patient comes with weakness, first you should differentiate whether it is a lower motor neuron weakness or an upper motor neuron weakness. Then identify the anatomical localization and etiology of the lesion. Following points in history must be inquired into so as to classify the presenting pattern of weakness. This will help not only identifying the underlying etiology but also determining the prognosis and deciding the therapy. Ask about the onset and progression of weakness and the duration of weakness. Pattern of weakness is very important whether it is a proximal or a distal weakness. Proximal weakness indicate LMN lesion and distal weakness indicate a UMN lesion. Ask about the pattern of progression of the weakness. Ascending weakness indicate Guillain-Barré syndrome and a descending weakness indicate tic paralysis. Ask whether it is symmetric or asymmetric. You should also know the presentation of muscle weakness in particular area. Ocular muscle weakness will result in ptosis and double vision. Facial muscle weakness result in incomplete closure of the eyelid and facial asymmetry. Palatal muscle weakness produce nasal voice. Pharyngeal muscle weakness result in dysphagia, choking and aspiration pneumonia. Weakness of the truncal muscle will lead to lumbar lordosis, scoliosis and truncal instability. Shoulder or arm muscle weakness produces winging of the scapula and difficulty in combing hair. Forearm or hand muscle weakness produces finger or wrist drop. Pelvic or thigh muscle weakness produces waddling gait so that the patient cannot rise from chair or squatting position. Leg or foot muscle weakness produces foot drop. The patient cannot walk on heels. Respiratory muscle involvement result in dyspnea and orthopnea. Then autonomic involvement leads to diarrhea, orthostatic dizziness, urinary retention and palpitations. Then you should inquire about the sensory symptoms in the patient. Ask whether the patient has numbness, paresthesia, allodynia, loss of proprioception and any sensory ataxia. Also ask about autonomic symptoms such as loss of sweating, hair loss, orthostatic hypotension, bowel and bladder symptoms. History can give you important clue to the etiology of the lesion also. Ask whether the patient has any recent illness or immunization such as diarrheal or respiratory tract infection, anti-rabies vaccine or oral polio vaccine, which all will result in demyelinating illnesses. Ask whether there is any recent travel, any history of dog bite, any precipitating factors such as exertion or carbohydrate loading which indicate an underlying periodic paralysis. See whether the patient has any fluctuation in weakness, indicating a myasthenia gravis. Ask about the history of drug or toxin exposure and any family history of weakness to rule out underlying porphyrias. Physical examination is also very important to identify whether it is a LMN or a UMN weakness. You should do a good head to foot examination, then examination of the respiratory system, cardiovascular system, musculoskeletal system and gastrointestinal system. And in the neurological examination, you have to examine for the higher mental functions, cranial nerves, bulbar weakness, extraocular muscle involvement, presence of ptosis, cerebellar functions and sensory functions. Motor system examination, you have to examine for atrophy of the muscles, fasciculation, evaluate the muscle tone, see for any percussion myotonia and concentrate on the deep tendon reflexes. Deep tendon reflex will help you to differentiate whether it is a lower motor neuron or an upper motor neuron type of weakness. In a human lesion, you will get hyperreflexia, and in LMN lesion, there will be hyporeflexia. Neuromuscular junction disorders, the deep tendon reflex is either normal or decreased. And in muscle disease, the reflex is normal or decreased according to the proportion of muscle weakness. Thank you.